Welcome to BFR Radio, a podcast dedicated to all things blood flow restriction training. This podcast is proudly sponsored by the BFR.co, where if you want to buy your own BFR cuffs, access online BFR training programs, or you want more information about this type of training, this is your one place to go. And I'm your host, Dr. Chris Gavilio. Welcome back. Hope you're doing well. In the last episode, we focused on the hamstring, specifically how BFR can be used to manage load, preserve muscle capacity, and in some cases, replicate adaptations normally associated with much heavier resistance training. In this episode, we shift our attention to the upper body and look at the shoulder. And the shoulder presents a very different rehab problem to the hamstring. It's a highly mobile joint, heavily reliant on neuromuscular control, and often surgically stabilized because excessive movement has become pathological. The issue here, as with most post-operative situations, is that the structure needs to be strengthened for protection. But prolonged unloading leads to rapid strength loss, impaired motor control, and delayed return to performance. To explore this, I'm going to walk through two complementary papers. And the first looks at blood flow restriction in a post-surgical shoulder population, specifically following shoulder stabilisation surgery. Importantly, this study does not compare BFR to non-BFR. Instead, it asks a more fundamental question. Is BFR even feasible, safe, and clinically meaningful in this context? The second paper then builds on that foundation by comparing BFR versus non-BFR shoulder training in a controlled setting, allowing us to explore whether BFR meaningfully improves strength and muscular adaptations at the shoulder. On to the first study, and it's titled The Effect of Blood Flow Restriction Therapy on Shoulder Function Following Shoulder Stabilization Surgery, a case series. This paper was published in the International Journal of Sports Physical Therapy and involves military cadets who had undergone shoulder stabilization surgery. The majority of procedures were Bankart repairs, which is a repair of the anterior inferior, or rather the lower front part of the labrum in the shoulder. This is often a result of shoulder dislocation. Surgery aims to reattach and stabilize the labrum, restoring normal shoulder function and reducing the risk of future instability. If we look at this type of injury and return to sport, it typically occurs 6 months post-operatively, with time from surgery used as the primary measure of readiness. However, when we look at athletic populations, they often lack rotational strength and upper extremity performance, with only 80% of athletes and only 68% of overhead throwing athletes reaching their pre-injury play level. Since the rotator cuff stabilizes the humeral head within the glenoid, incomplete recovery of rotational strength may contribute to recurrent instability and failure to return to sport following shoulder stabilization surgery. The challenge is that traditional strength training loads, typically at 70 to 85% of 1RM, is often not tolerated early after surgery. We've established that. Pain, apprehension, and tissue healing constraints all limit mechanical loading. Subsequently, this is where BFR offers a workaround, creating a high internal stimulus while keeping external loads low. Now that we understand the background to this injury, let's understand what they did. This was a prospective case series involving 18 military cadets who had undergone shoulder stabilization surgery. As we said, the majority were Bankart repairs. Participants began training at post-operative week 6, once they were cleared from range of motion restriction and allowed to commence isotonic resistance training. And they performed 2 to 3 rehab sessions per week. For the surgical extremity, participants selected a resistance at an RPE between 7 to 9 out of 20, which is labeled as extremely light to very light. And this is said to correspond to 30% of a 1RM effort. They also trained their non-surgical extremity, but used a heavier resistance, self-judged at an RPE between 15 to 17 out of 20, which sits between hard to very hard and corresponds to between 70 to 90% of 1RM. The BFR cuffs was applied to the upper arm of the surgical limb, with a pressure set at 50% of limb occlusion pressure. Inflation was continuous and was capped at 30 minutes per session. And the cuff was 4.5 inches wide, which pretty much takes up most of the upper arm width. As we know, BFR cuffs come in all different widths, and that's one of the considerations with it, is how wide the cuff is, which relates to how much pressure or a percent of limb occlusion pressure. And also it can affect range of movement. When we look at the session, it consisted of a warm-up followed by 3 resistance exercises targeting the rotator cuff and periscapular musculature. And they were 1, external rotation, 2, scapular retraction with a shoulder extension, and 3, scapular plane abduction. For the surgical limb, exercises were performed using the 75 rep protocol. That's 4 sets, 30 reps, followed by 3 sets of 15. And the non-surgical limb trained without BFR performed 4 sets at 12. The primary outcome measures used included shoulder isometric strength, that's external rotation, internal rotation, and abduction using a handheld dynamometer, and patient-reported function, which was measured at 6 weeks, 12 weeks, and 6 months post-surgery. Secondary outcome measures included active range of motion and a battery of upper extremity performance tests measured at the same 3 time points. Before discussing those results, I just want to briefly explain the performance tests used so it makes a little bit more sense to you. The first performance test was called a closed kinetic chain upper extremity stability test. This is a closed chain stability test performed in a push-up position. Hands are approximately 90 centimeters apart, and the athlete alternates touching one hand to the other as many times as possible over 15 seconds. And when we look as a reference, a score of greater than or equal to 21 touches is considered above average for healthy college-age students. The second test used the upper quarter Y balance test. Now, if you're a strength and conditioning coach or a clinician and you've heard of the Y balance test for the lower extremity, this is pretty much the upper extremity test. And you're in this push-up position, and the athlete will reach in 3 directions with the free hand while maintaining trunk and shoulder stability. Now, when they do this test, you will sum the average of reach in each direction and calculate a composite score to normalize for limb length. And they'll also calculate a limb symmetry index. And they do this by dividing the composite score of the surgical extremity by the composite score of the non-surgical, and then multiply by 100. And what we're looking for is something of a limb symmetry index of 95%. The third performance test was a single arm seated shot put test. They'll use a light medicine ball at 2.72 kilograms and have to throw it from a shoulder height as far as possible. A limb symmetry index of 90% accounted for limb dominance and was considered normal. Onto the results and looking at improvements in strength, the data was presented as normalized data. So although I can't give you absolute or percentage change, the results did show that from week 6 to 12 post-surgery, statistically significant and clinically meaningful improvements were observed in the surgical limb for all 3 measures. That was external, internal rotation, and abduction strength. That's going away from the body. Interestingly, no significant strength changes were observed in the non-surgical limb. And when we look at the results for the patient-reported outcomes, I didn't actually go through this earlier, but there's 2 scores that they did. The first assessed shoulder function using the single assessment numeric evaluation, or SANE, or SANE score. And this is a really simple measure where participants are asked one question: how would you rate your shoulder function today as a percentage of normal, where 0 represents no function and 100 represents normal function. Although it's pretty simple, the SANE score has been shown to be reliable, valid, and responsive in shoulder populations, particularly following surgery. Importantly, a change of approximately 15 percentage points is generally considered clinically meaningful. In this study, SANE scores increased by 17.7 points between 6 and 12 weeks post-surgery. So that tells us that the participants did not feel just marginally better, they perceived a substantial improvement in how their shoulder functioned during daily and athletic tasks. The second key outcome measure was the Shoulder Pain and Disability Index. And this is more detailed than the single assessment numeric evaluation. It's designed specifically to capture shoulder-related pain and functional limitation. It consists of multiple questions divided into pain and disability subscales, producing a score where higher values indicate greater impairment. A reduction of approximately 18 points on this scale is typically considered clinically meaningful, and in this study, the score decreased by 31.1 points from 6 to 12 weeks post-operation. As we can imagine, the magnitude of change is pretty substantial. When we turn our attention to the performance test results across the cohort, the authors reported a significant mean effect of time for all three performance measures. In practical terms, this means that the performance on the closed kinetic chain upper extremity stability test, that's the push-up position where you're tapping each hand as quickly as you can for 15 seconds, the upper quarter wide balance test, and the seated shot put improved progressively from the early post-operative phase through to the final assessment point. By the final testing time point, more than 70% of participants were able to meet reference values on at least two of the three performance tests. This indicates that most individuals regained acceptable function in multiple domains. However, when stricter criteria were applied, specifically meeting reference values on all three performance tests and demonstrating symmetrical strength, only 3 participants achieved this benchmark. This finding is pretty important because it highlights the discrepancy between improvement and complete functional restoration. And look, to be honest, the shoulder does get better across time, and it's all individual. Overall, the results do highlight a statistically significant and clinically meaningful improvement in shoulder strength and self-reported function in participants who did perform BFR training twice a week. No adverse events occurred, and no participant discontinued the BFR treatments. However, we must also highlight that there was no control group. This is where a similar group would perform the same training without the BFR. Despite this, the results from the study show us a method to improve shoulder strength and function during a period when we just can't load it like we want to. This takes us to the second paper, and it's titled Blood Flow Restriction Training for the Shoulder, a Case for Proximal Benefit. While the first study asked whether BFR could be used safely and effectively after shoulder stabilisation surgery, the second study asked a more mechanistic question. Can applying BFR to the upper arm influence strength and muscular adaptations at the shoulder, even though the shoulder musculature sits proximal to the cuff? This concept is often referred to as proximal benefit, and it challenges the traditional assumption that BFR only meaningfully affects muscles distal to the site of occlusion. Understanding this paper is pretty important in my opinion because it helps explain why we might see improvements in shoulder strength in the first study, even when heavy loading is restricted and the cuff is not placed directly over the shoulder musculature. Unlike the first paper, it does not involve a post-surgical population. Instead, the study was conducted in healthy individuals, and participants were allocated to one of two groups. Both groups performed the same shoulder training program using the same exercises, same training frequency, and the same relative loading. The only difference between groups was whether BFR was applied. Training was completed over an 8-week intervention period, and they trained twice a week. In each session, the participants performed 4 exercises which targeted the rotator cuff and shoulder musculature. These were cable external and internal rotation at 0 degrees, which corresponds to having the arm beside the body, dumbbell scaption, and a side-lying dumbbell external rotation exercise. Training loads for both groups were initially set at 20% of isometric maximum. For each exercise, the participants performed 4 sets. First set was 30 reps, followed by 2 sets of 15 reps, and the fourth and final set was to fatigue. Rest periods were set at 30 seconds between sets and 2 minutes between exercises. If in the final set of each exercise they could achieve 15 reps or more, in that next subsequent session, that would increase the weight by approximately 0.45 of a kilogram. For the BFR group, the cuffs were set at 50% of limb occlusion pressure, and it was a continuous inflation for the entirety of the whole session. For testing, they looked at changes in lean mass, isometric rotator cuff strength, strength endurance, and muscle activity. Now, when we look at lean mass, this was done using a DEXA scan. They took two measurements, one being the upper extremity, which was essentially the full length of the arm, and the second was just the shoulder region, which included the trapezius muscles. The advantage of using a DEXA scan is rather than looking at overall size and circumference as we normally would with a tape measure, it can actually give us the specific change in the muscles. And then after that, they performed maximal shoulder strength, focusing on rotator cuff, and they performed 6 different isometric tests covering internal and external rotation at both low and high shoulder angles, as well as forward flexion and scaption. In each case, participants pushed as hard as they could against a handheld dynamometer for 3 seconds. Repeated 3 times, the best effort was used for reporting. Next came the strength endurance tests. The participants performed a single set to fatigue for 3 exercises: standing cable external rotation, standing cable internal rotation, and dumbbell scaption. And all of these were performed at 20% of their maximum strength. Now, here's the interesting part. These endurance tests were performed both with and without blood flow restriction at 50% of limb occlusion pressure. The order of BFR and non-BFR testing was randomized, and the cuffs were deflated between exercises. Now, this was performed irrespective of whether you trained with the BFR cuffs on or not. During the tests, the researchers recorded muscle activation using service EMG, placed over key shoulder muscles, including the deltoid rotator cuff and the trapezius. They really just wanted to see whether muscles were working harder or differently when the BFR cuffs were applied. So by the time they got to the results, the authors weren't just asking, did people get stronger? They were asking, did the muscle size change? Did maximal strength change? Did fatigue resistance change? And did the way the shoulder muscles recruited change as well? Which now takes us to the results. And when we start off by looking at lean muscle mass, only the BFR group demonstrated a statistically significant and very large increase in upper extremity lean mass across the intervention. In fact, the non-BFR group had a group average loss of 17 grams compared to 175 gram increase in the BFR group. For the shoulder region, both groups increased lean mass in the shoulder region, but the magnitude of increase was greater in the BFR group by almost 3 times compared to the non-BFR group. When we move to maximal isometric strength, the findings become more selective, and across the 6 strength tests performed, the BFR group had varying levels of strength improvements, and only one movement demonstrated a clear between group difference, and that was internal rotation strength at 0 degrees with the arm beside the body. For this measurement, strength increased from approximately 20 kilograms pre-training to 23.1 post-training, representing a mean increase of 2.9 kilograms. In contrast, the non-BFR group showed essentially no change, increasing by only 0.1 kilograms over the same period. For the other 5 measurements in the non-BFR group, they had varying levels of increase and decreases. The most striking results, however, emerged when looking at strength endurance. All participants performed single sets to fatigue at 20% of maximal isometric strength, and both groups improved across all endurance measures. However, the magnitude of improvement was considerably greater in the BFR group, particularly for internal rotation. In particular, the BFR group increased total achievable volume by approximately 158 kilograms under the occluded conditions and 157 kilograms under the unoccluded conditions. In comparison, the non-BFR training group improved by only 75 to 93 kilograms, depending on the condition. When expressed relative to the control group, this result represents approximately a 2-fold greater improvement for the BFR group. The key point here is that the superior endurance performance in the BFR trained group was not dependent on wearing the cuffs during testing. This means the adaptation carried over when the cuffs were removed. The BFR training did not universally enhance endurance across all shoulder movements, but it produced large and transferable improvements in internal rotation endurance, or rather it improved in movements that were similar to the exercises performed. And I've always advocated that exercise selection is key, and this is a great example. Finally, the authors examined muscle activation using service EMG during the endurance testing. When comparing occluded versus unoccluded conditions, BFR consistently resulted in higher muscle activation across several key shoulder muscles. During the cable external rotation, greater activation was observed in the posterior deltoid, infraspinatus, and teres minor. And during cable internal rotation, higher activation was seen in the anterior and posterior deltoid and teres minor. And during scaption, all analyzed muscles demonstrated higher activation when wearing the BFR cuffs. When you step back and look at these findings collectively, a very clear message emerges about where BFR fits, and just as importantly, where it doesn't. First, this study shows that BFR does not produce blanket improvements across all shoulder outcomes. We saw that the strength gains and also the endurance gains were pretty selective according to the movement. That immediately challenges any idea that BFR is a shortcut or replacement tool for well-designed training. Before we move on, I feel it's worth making one other important clarification. In my opinion, BFR should be not viewed as a tool that only belongs in low load or rehab settings. There's now a substantial body of evidence supporting the use of BFR alongside moderate and even high resistance training exercise. So when we talk about BFR in this episode, we're not talking about a narrow technique reserved for one phase of rehab. We're talking about a method that can be systematically applied across the full loading spectrum, depending on the goal. With this said, the next phase that I want to just briefly mention on is actually if we would take one step back, and that's in that early acute post-operative stage and immediately following surgery, where the movement is typically restricted and you have pain and swelling present. The primary concern is not performance, it's not even strength, it's preventing rapid muscle loss and deconditioning. And we know from a large body of literature that muscle atrophy begins very quickly following surgery and immobilization. Once that loss has occurred, it becomes much harder to reverse later on. Therefore, as we could imagine, the challenge in the acute postoperative phase is that we have very few tools available. This is where passive BFR becomes particularly relevant. The cuffs are placed proximally on the limb, inflated for short periods, and then released typically in cycles of 3 to 4. At first glance, this might seem too simple to actually make any kind of change, but there's actually quite a lot of evidence to say that it is worthwhile adding it into your own rehab program. From a clinical standpoint, this reframes that early postoperative phase. Instead of being a period of complete physiological stagnation, becomes an opportunity to limit regression, maintain tissue quality, and potentially improve readiness for later active rehabilitation. When we link this back to the studies we've just discussed, the logic becomes clear. If BFR can enhance strength and endurance adaptations once low-load exercise is introduced, and if passive BFR can help preserve muscle when exercise is not yet possible, then BFR becomes a continuum-based intervention, not a single technique. And if we zoom out and look across both of these shoulder studies, what emerges isn't a single BFR protocol or a one-size-fits-all solution. What emerges is a framework for decision-making. The post-surgical case series shows us that BFR can be safely integrated into shoulder rehab and is associated with meaningful improvements in strength and function during a phase where loading options are limited. The Proximal benefit study then helps explain how these improvements might occur. It shows that when BFR is laid onto low-load shoulder training, it can selectively enhance adaptations, particularly strength endurance, and that those adaptations persist when the cuffs are removed. And when you then add passive BFR into the picture, the clear continuum starts to form. In the very early post-operative phase, when movement and load are restricted, passive BFR offers a way to apply a physiological stimulus when the exercise isn't yet possible. As active movement is reintroduced, BFR can be laid onto low-load training to bias adaptations that otherwise would be very difficult to achieve. And later still, BFR can be used alongside moderate to high loads rather than being removed entirely. That shift in thinking is important because it moves BFR out of the category of a niche rehab tool and into the category of a systematic training variable, something that can be manipulated just like load, volume, or exercise selection. And that ultimately is the key message from today's episode. BFR isn't about shortcuts, it's about strategic constraint, using physiology to maintain or build capacity when training loading isn't yet appropriate. And that's where we'll leave this episode for today. If you have any questions related to this, you can get in touch with me through my website or socials at thebfr.co. You can also purchase your own BFR cuffs from our website, and you can find it at www.thebfr.co. And lastly, before I go, a couple of favors from me to you. If you know of someone who would benefit from this episode, please share it. And if you are enjoying the podcast, please give it a rating on iTunes. Thanks for listening, and remember to keep the pump.